Good morning, everyone. Thanks so much for being with us today. I'm Suzanne Spear, Director of Workforce Development here at ACU. This is the fourth and final installment of ACU's webinar series on compensation strategies. We've archived the first three parts of this series on our website in case you missed them. Today, we'll be looking at providers, staff, and incentive pay. We are excited to once again have Ed Ura with Merces Consulting with us today. So Ed, go ahead and take it away.
All right, thank you, Suzanne. I'd like to also welcome you this morning, or whenever you're actually listening to this. This is the fourth part of our four-part presentation, and to remind those of you who have been part of our project all along, or for those who are new to it, we began in our first webinar with an overview of what makes a comprehensive and effective compensation program for our staff. And this was designed to be an introduction to a tool that we will be providing you that will allow you the opportunity to plug in some numbers and answer some questions and find out how your staff compensation program stacks up. In our second webinar, we spent some time talking about how to set the pay of an individual employee using this effective compensation program. We then went into a bit of a conversation in our third webinar about what happens when we don't have effective staff compensation programs, looking at the negative implications everywhere from lost productivity to turnover and the various issues that often plague many of our organizations, and particularly those who are unable to deliver pay. So today, we're going to focus on providers specifically, and also talk a little bit about incentive compensation for both providers and staff. And in a way, you'll see, for those of you who have attended our other three webinars, you'll see that we've kind of been moving toward this concept or this topic of provider pay, because provider pay, although is frequently focused on as the thing for recruiting and retention, it's actually one of the last things that we need to think about when it comes to recruiting and retention. Because the first thing we need to do is provide an attractive setting for our providers, both when they come to talk to us and when we're in the recruiting mode. And then as they come to work for us and become part of our organizations, we need to have an environment that facilitates their work. And as we all know, pay is big, but pay isn't everything. And so we've talked a lot about how we set the stage for an environment that is effective for recruiting and retaining providers. And now we'll talk about some of the specific issues related to pay. Those of you who have listened in on previous webinars know that I like to start with this particular quote from Sun Tzu in The Art of War. Victorious warriors win first and then go to work. Go to war while defeated warriors go to war first and then seek to win. And I think it's particularly appropriate to have that quote today, particularly when we talk about incentive compensation. One of the hallmarks of incentive compensation is that you basically get one opportunity to do it right. And if you don't do it right, you lose credibility. No one believes you for this time or the next time. And frequently it may take years to be able to get another chance. And so it's very important when we're talking about how we're going to structure compensation, particularly incentives for our providers, to make sure that we do it right. So what are the issues we want to cover today? Well, there are basically three areas, and some of these are just a recap. So with respect to staff pay, we want to just note and remind ourselves that the organization and our providers can't be productive or effective without good staff. That's just a function of what we know to be the case. We also know, and we've talked about before, the fact that effective pay programs are central to the ability to recruit and retain good staff. Now, as has been noted by many people, including me, pay is obviously not everything. However, pay is central to it. And there have been studies that we've talked about before that indicate that pay is both the primary reason why people leave and the primary reason why people stay. And as a result, there's so much opportunity there, and it's so essential that we do this so that the other advantages that we have as organizations are things that can actually come out and be useful. So when we move on to provider pay, there's a couple things we want to talk about. The first thing we want to note is that base pay is the first bottom line. There are a lot of great discussions we can have about how we add up all of the elements of compensation and all the elements of indirect pay and the work environment and everything. But the first number that anyone's going to see is base pay. And it's essential that base pay is handled correctly. The biggest problem, of course, right now is that base pay maintenance is the most important challenge today. We have a market that is moving rapidly. In some cases, for some provider specialties, 6 to 8 to even 10% a year. And having the right number when we start is just part of the situation, it's part of the problem. What we have to do is make sure that we are recognizing both the growth of individual providers and the fact that the market is moving dramatically. One of the biggest problems we see as we talk to our clients and other organizations is that they may have people who are more than satisfied with what they're earning right now, but the minute we go out and hire someone fresh out of residency for $30,000 more than they're earning, all of a sudden pay becomes an issue. It's not the bottom line number all the time, it's how it relates to other people, and particularly how it relates to people who are new to the organization. So we want to make sure we focus not just on setting that base pay number, but also maintaining the base pay number. We'll move into incentive pay, and we're going to note the challenges in incentive pay. And I'm going to suggest to you that you should only try it when everything else is done. Don't use incentive pay to make up for other deficiencies in the organization or deficiencies in performance, but address those other things first so that when you get to the point where you're considering incentive pay, you're actually doing it when you have distances to make up that you can say are distinctly related to people and their performance. And also, don't try it until you know what will happen. Many times, incentive compensation plans are designed frequently by people with no experience in designing incentive compensation plans and then implemented without testing or modeling. And that is the sure way to ensure that it's going to fail. So we will talk about some of the issues that are important for you to consider when you're looking at an incentive compensation program. So let's move on to our first topic here, which is really essential to this idea of how much someone's base pay is going to be. And what that means is that you have to determine as an organization the value of each and every provider specialty or every provider role. And it's usually done a little bit differently than it is for staff. We talked in the staff compensation programs about using job evaluation methods and assessing the differences between jobs. But there's more to do when it comes to providers because they are so market-based in terms of the competition. So what the first thing you have to do in determining the value of a provider to you is to determine what the purpose of the job is. We'll frequently come across a job description for a physician that says treats patients. And while that may encompass the general concept of what a physician is supposed to do, it actually very rarely encompasses all the various things that we're going to ask our physicians to do and the level of performance that they're going to have. So our first key in determining the value of a provider is to determine what it is that you expect out of the job. So you should have an effective job description for every role, including all of your provider roles and all of the specialties. That job description has got to go beyond simply treating patients, but address issues like productivity and address issues like quality and collegiality and working with staff and developing colleagues and the like. It really, and even attending meetings and participating on task forces. You need to let your folks know, particularly when they're being hired, what the expectations are. Frequently, we're focused more on the pay and here are the facilities, and we don't talk about all the things that our folks are going to need to do. So it's essential that we define those expectations in the job description. We want to make sure that what we're doing is defining what we can see. Actual behaviors. It is no different for a dentist or a hygienist or a nurse practitioner than it is for a medical assistant or dental assistant. When we're assessing their performance or when we're determining their individual value, we have to be able to do it in a way, in things that we can actually see. And that doesn't mean numbers, but it means things that we can see. We need to have things that are objective, those things that don't require opinion to know if they're met. Because again, when we're talking about highly educated individuals performing crucial roles, there is a tendency to believe that that a lot of it is sort of fuzzy and a lot of it is just things that you know about people. But then we can't translate that all the time into an actual discussion, into actual performance management, or actually determining what pay should be. So we need to look at things in our job description that are objective, things that we can see, and we need to focus, as we would do on any other job, about mastering the job. That is, someone is doing the job the way we want it, they have mastered the job, and if they have mastered the job, just like any other individual in the organization, we want them to be paid at the value that job has to us. So what our challenge then is making sure that we've actually defined that job so that we know what we're comparing to. What we have to do then, once we have the responsibilities and the expectations of the job, is to ensure that our target pay, that is the amount that we want to budget for, the amount that we want to ensure we're delivering, is sufficient to recruit and retain providers at the value you've established. So there are a number of things that go into this. The first thing being that you have to know if your desired performance is matching up with the benchmarks in the industry. For example, in our most recent survey on provider incentives, our provider compensation and productivity, we noted that the typical expectations of providers with respect to productivity, and not even addressing all the other issues, those numbers are typically significantly higher than the actual productivity that is being generated. So are we looking at what expectations are, or are we looking at actual productivity? We need to know what the typical performance of an individual is at various levels of pay to make sure that we're lining them up. If we're expecting to have median or middle of the market performance, then we need to deal with median or middle of the market pay. If we're expecting performance or performance expectations are significantly higher than the market, then it's essential that we look at a position in the labor market that is significantly higher in order to make sure they match. So we have to make sure that we have benchmarks not just on pay, but benchmarks on the levels of performance that we want. We also have to make sure, of course, that the defined performance and the pay associated with it will actually be financially supportive. That is, folks have got to pay for themselves. And if we have set our pay rates too high for the revenue that they're going to generate, we're obviously going to have problems, and that's just some basic finance. But the idea is it should be worth it. So I have worked or reviewed pay programs in a number of organizations and sometimes looked at the amount that is being paid, particularly sometimes incentives, and have to sit back and say, I'm sure the providers are very happy with this, but when you're paying somebody, 100% above the market, shouldn't that money be focused on our other services rather than being paid to our providers, regardless of how much productivity they have? So we have to look at not just, are people happy, but what does it mean to the organization and our ability to provide all of our other services? We also have to realize, and this is so important right now, that the target is moving. What we thought was competitive pay 5 years ago is 20 to 30% behind what it is right now. And if we're not keeping up, we are leaving ourselves open to the possibility of other people cherry picking our people. And we know that that's what recruiters are doing right now. They're making their calls. There's a shortage of people. They need to find them. So what we want to make sure is that we know what all of that is. So how do we understand this market data that we get? Lots of people tell us about the number or what the numbers are or what they have to be. We want to make sure, first off, that as we're looking at market data and surveys, that we are comparing apples to apples. That is particularly an issue with respect to provider pay because all of the sources give us different information. So what do your sources report? My biggest example for this and my biggest caution to folks is using the Medical Group Management Association data, MGMA. Very common source of information used by health centers and used by all kinds of organizations. And they'll look and say, well, we can't meet these numbers, or they'll look and say, these are the numbers we have to meet. And the point that I would raise when folks are doing this is to recognize that that survey is not providing you with base salary information. It's providing you with total compensation information, which means the value of the base salary, the value of any bonuses that are granted, the value of any distributions from for-profit organizations, continuing education money, or company cars, whatever it is that the organization is giving is lumped into that number of total compensation. So if we're comparing an MGMA number to a number from one of our other surveys or our own pay, recognize that that number should be significantly higher than what we are actually doing when we're looking at our base pay. Also note that when you get data from recruiters is not survey data. It is not data talking to how much people are actually paid. It is talking to the question of what is it going to take for you to hire somebody? And that's a completely different number than what people are actually being paid. So we have to be very careful with every source of data to make sure we understand exactly what it is that it includes. So what is included in pay? Is it incentive compensation in an environment where base pay is kept low so that we can keep cash flow good, which might be typical in a private practice? We need to focus on the fact that in our world, as health centers, as providers of care to the underserved, we have a different model than a hospital. We have a different business model than a private practice. And our pay programs need to look like those, and they need to support those, not hospitals and private practices. We also have to look at what we need to overcome and how it affects compensation philosophy. Typically, we find anywhere between a 10 and 20% difference in market rates between urban and rural areas, with rural areas being where the pay has to be higher. This is a direct opposition to staff pay, where staff pay in rural areas tends to be lower. So we have something that we need to be aware of. We need to look at the attractiveness of our area and what it may take to bring somebody in. We may have to pay more simply to get somebody to come into our area. I had a client once a number of years ago that used to complain about how quickly they lost their young folks out of residency that were getting their loans paid off. And of course, we know that it's very typical for that to happen. But the biggest issue that was brought up by these folks when they were leaving is that there was nobody to date in the town. There was literally no social life for these folks. And so they went back to the big city. And these are the things that we have to understand. And it's not just money. There are a lot of things that simply money can't buy. And sometimes that's as simple as a social life. We know, as I mentioned just earlier, how our performance expectations going to line up with the pay that we're going to offer. So we also have to look at what are the differences in the job. And sometimes these are the positives, the things that we sell to folks. Focusing on the mission versus the profit nature of the business. That's part of it, as is the schedules that people will work and how they may be better than their private practice alternatives. Being an employee versus an owner, it has both positives and negatives. And we know that many times one of the attractive things that we can offer is to take the headaches away from those who don't really want to run their own businesses. But we also have to understand and appreciate the negatives. And I think this is something that frequently is not done. One of the biggest being the loss of control. We have a highly educated, very talented workforce here that with folks who really do know what it takes to deliver care. When they find themselves as employees who are being directed in their work by people who are not in their own profession, that can cause a significant issue. And sometimes that in and of itself, the loss of control, will be the biggest reason why you lose people. So now that we've got kind of an idea of how complex market data actually is, we need to look at how that translates into what we're going to pay somebody. So what I've put up here on our screen is a very simple model, and I would like to note that the numbers in here mean absolutely nothing. They are not intended to be recommendations. They were just numbers. But we put this together for a client as an example a few years ago to talk about how we develop our value. So we know what we need, we know what our expectations are, and what we try to do with that is to look at, in this case, the green band here of our pay range, which represents the middle or the target, and what we would pay somebody at that level. That's expressed in the range, but what are the criteria to get there? Whether you're using this as a way to look at your current workforce or to design a program in the future, it's really essential that we know everything that we need. So in this case, we just put together a hypothetical at doing the job the way we want the job to be done as an organization. these are the numbers that we would expect people to meet. And as of course I've mentioned earlier, some of these numbers will be meaningless because they were just numbers thrown out to create something. But what we can do by doing something like this for your organization, what you can do is identify, based on that job description, what the expectations are, translate it into numbers, so that you know that when one of your providers is performing at the level that you expect of them, this is what they should be paid. And you can define that for the various parts of the range. You can use this as a way of explaining to somebody coming in out of residency, these are the things that you will need to do, and this is how you will develop. But it's really key to make sure that in this case, the green part of the range that I've identified here is associated with doing the job the way the job is supposed to be done, or mastery. So we want to tie our job description to our market data, to our criteria that we're going to use to measure how somebody has developed or grown. Once we have that, first of all, this gives us something to budget with. If we know that we need 10 family practice physicians and that over time they all have to be performing at level X in order for us to meet our patient load, we know what to budget. We know what that cost is going to be, because frankly, we can't control what people's value is. It would be nice if we could just say, we're going to give you a 3% increase every year or a 2% increase every other year. We can't control that. We do not have the ability to do it regardless of the way our income comes in. We have to know that we have an expense that is outside of our control, and that if we don't meet this expense, we will not be able to meet our mission. So for every job, something like this, whether it's graphic or in text or whatever it needs to be for you, can give you an idea of what the value is of various levels of performance to you, and to illustrate to your providers and to your administration, if you have to do some selling that way, this is what the cost will be. Now, what's important, as I noted earlier, is the biggest issue right now is maintenance of pay as opposed to that initial number. So what we need to do is look at something that's really fundamental, and that's how people grow. And people grow in a job relatively quickly at the beginning, and then they begin more to refine their skills rather than to develop them. And you'll see that regardless of what kind of job you're looking at. So if we looked at a front desk person, for example, you know that the vast majority of that growth and that development is going to be in the first year. And if they can't handle the job in the first year, we know they're not going to be able to it. But if you look at jobs that take longer to learn, ask yourself the question, how long should it take for a physician coming out of residency to become at our mastery level that we've defined, to meet the expectations of the job? Do we expect that to happen in 2 years? Do we expect it to happen in 5? Or do we expect it to happen in 7? Whatever it is, we know that the largest chunk of that is going to come in the first year. And that's one of the reasons why people become so much more marketable after just 1 or 2 years, because they have developed so much. So what we have to do is recognize that when we're paying our providers, just like any other staff member, but particularly because the numbers are so dramatic, we need to keep pay up at the beginning of the career to get people to where they're supposed to be. And if we look at our pay as what percentage of our target we want them to have reached, the largest increases should be at the beginning of somebody's career. And as they develop, and as they get to what we would consider fully functioning or having mastered their job, increases are more going to be based on changes in the market than they are individual performance. So if we want to look at that as people moving through the range, we recognize that there are a couple of things going on here. Our ranges are moving, and in the case of many provider roles, our ranges are moving rapidly, and we have people's growth, as was illustrated in the previous slide. So if we look at, this is a sample of 5 years worth of projected market rates, and these numbers, of course, are also meaningless because my crystal ball doesn't go that far. But if we look at how ranges can move over time, you see every year the range shifting over slightly as the market rates increase. This blue line represents somebody who we've hired in, again, perhaps right out of school or out of residency, someone with limited experience, and recognize that over the course of probably 5 years or less, we need to make sure that their pay moves from wherever it is now to where it should be in the future. And that means that increases need to be relatively large. We can't bring somebody in and expect, that we can give them 3% a year and that they will be happy. In fact, the truth is, for somebody at this level, if we know the market is 6%, moving at 6% a year, we can't just give them 6% a year, because that will never make up that gap that blue line represents. Of course, when we bring in somebody who's more established, someone who has, maybe already is reaching the levels of performance that we want, the grayish white line represents that situation. Because then what we're doing is we're maintaining. We're in a maintenance mode where we're making sure that we are not slipping behind the market. And of course, our final red line is unfortunately one that many of us are used to, the idea that there will be times when we have to pay sometimes well above what we would like to pay based on our own structures. And what we're trying to do then is limit increases so that we don't have people going completely out of our budgeted means. It may mean that people will still get increases, but they won't be as large. So this gives you an idea of why it's so important to recognize that there are two things going on here when we're talking about maintaining pay. We need to maintain their pay with respect to the market and with respect to their growth. So what happens if we don't do this? Well, if we don't do this, we have a big problem, and that's illustrated by this exhibit. So the green line here represents the value of an individual in say a family practice role who might be coming out. In our last survey was that those hiring rates overall nationwide a couple of years ago were about 150,000, 155,000. What you see is relatively rapid growth in the first 5 years, which is illustrated based on our previous exhibit. And then the line tends to increase a little at a more gradual rate, but is still increasing over time. What frequently happens, however, is even if we hire someone at the right rate, look at that bottom red line. That's what happens if we give somebody a 3% raise every year. And what you'll see happens is those lines they don't get closer. They actually start getting farther apart. If we change that to 5 years, we still are going to have an issue because the 5% is not enough over time. And we may be getting closer and we'll reach our green line faster, but we still won't get it in those key years when we're trying to make sure that we keep people. If we can keep someone in our environment, knowing everything from the patients to the financial opportunities to everything else, if we can keep somebody in our environment for 5 to 10 years, we're going to keep them. If we can't, you can kind of see why, because in years 2 through 5, that's where some of the biggest gaps are apparent for people who are looking at financial aspects of work. And if we're going to be that far behind, this is what's going to happen. So now we can actually really see what the issue is with bringing people into the organization at rates that are market competitive, but far above what we're paying people right now. And this is obviously not cheap. And I'm not going to give you the answer that, oh, you can just find the money somewhere. This is really to illustrate the need to recognize what costs are, the need to recognize and understand what this expense is and why it is not something that we can control as easily as we might like. So what we want to do then, knowing these things, is we want to measure and pay for actual growth. So we want to measure growth toward mastery of the job as it's been described. What percentage of each expectation is being met? We want to try to reduce this to numbers so that there are easy things that people can see to understand exactly what it'll take to move. What is the total amount of growth that someone has had over the past year? And also ask a question of when do we stop accepting less than mastery? One of the reasons that I am frequently given when I talk to people about why they want incentive compensation is that they will say, well, we want this because if somebody's performing below our expectations, we don't want to pay them as if they are. And I certainly agree with that point in general. But the problem with that is that at some point we have to look and see if performing, at 70% of our expectations after 10 years on the job is something we can actually accept. And if we're using incentive compensation to overcome that, we may be putting ourselves in a position where someone who is not performing sufficiently, and the number of patients we see doesn't change, the other folks around them have to see those patients bringing their numbers above their expectations, and we may be in a position where we're actually paying incentive compensation to cover for someone else's poor performance. And when we look at that from a business perspective, that's really not a good idea. And we really do have to have some mechanism for saying enough is enough. And I know that's very difficult for some people to conceive because we know how difficult it is to get people, but recognize that those poor performers are actually having an impact on our good performers. Our good performers resent those who are not pulling their weight, those who are making them work harder. And so, we may be saying, oh yeah, we have to keep these people, or what will we do? But realize that they may be doing us a lot more harm than they're doing us good, even being there. So we need to make sure that we're then paying along that growth curve. And there's a simple formula here. If you have a range of pay that's got a target and a minimum, such as what has been illustrated back up here a couple of slides, we can look at what percentage of the job has been achieved and then figure out what the pay should be along that growth curve. And that's basically the formula. So the biggest challenge is, as I mentioned, it's not setting that number in the first place. It's keeping up. It's making sure that our folks are actually being paid what their value is so that we don't lose them for pay purposes. So how do we plan for it? The question being, how do we pay for it? We need to budget at realistic costs. We can't take the amount of money that we are paying our providers right now and say, okay, we can increase that 3% because that's what the budget allows. That, in a lot of ways, is sort of backwards budgeting. It's trying to figure out the expense based on our income. And that's not something we can do with this particular group of individuals. We have to establish a baseline cost. If we know that we need 10 family practice physicians and we know what our target rate is for family practice physicians, what we need to budget for them is 10 times that number. Not what we did last year plus 3%, but whatever that number is. Now, if we budget that way, we may not always be spending it. In fact, frequently we won't be spending all of it. So, you can look at it as perhaps an unrealistic number because you don't always need it, but you have to know what that number is. So you can establish your baseline cost at the target. You can determine your actual cost based on each individual's performance and that little formula on the last slide, the idea that we can figure out what each individual person is worth. We can apply those growth curves to plan ahead. So budgeting is not simply we'll just add 3% next year. Budgeting is, we know the performance of our individuals will increase along this growth curve, and this is what the cost is going to be. It does require a little bit of crystal ball gazing, but if we know historically what's been going on in the market and we don't see any changes, we can assume that that's going to continue. So we should be able to make a plan for each provider. We should communicate it and stick to it. If we know what our performance expectations are, and we know what we are willing to pay at those various levels of performance expectations, there is no reason why we cannot communicate that to everyone and say, as you grow, as you develop, as you become more productive, as your quality increases, whatever it is that we are measuring, we will be paying you accordingly. That can be probably one of the best, from a pay perspective, communications efforts when it comes to recruiting and retention. We tend to focus on this is what the number is right now. And that's great for the first couple months, but then we're looking at what is next year's number going to be. We should be able to communicate that in advance. Even if we're saying all of this depends on our ability to pay because we are a not-for-profit organization, fill in the blank, you can put any caveat you want on it. But to be able to explain to people this is what the expectations are, gives them a better idea of what their future is, as opposed to just what they're going to start with. So let's move into incentives, and I apologize for the order of my slide not working right today. But I'm going to start with the question, now that we've got base salaries figured out, do you need incentives? So the first question you should always ask yourself is, what is the reason for incentives? Why are you putting together an incentive plan in the first place? Look at what the reason is. Is it to reduce risk or contain costs? I mentioned that as something that folks will often do. It's the idea that, well, we'll just pay a little bit lower, and if somebody performs well, we'll give them the rest of it. That's a behavior manipulation kind of thing, and finance folks like it. but people don't. So think about this idea of, do we want to impose reducing risk on some of our most important people? What's another reason for incentives? Because others do it. Well, who are the others? Maybe your recruiter says you have to do it. Well, why would they say that? Well, frankly, because they're going to get paid more. And we have to look at this whole idea of who the others are and why the others may do it. So, for example, I can tell you that in my last 5 consultations with folks considering provider incentives, every one of them told me that we have to do it because everyone else is. Well, I can tell you from our research that that's not true. Probably just over 51% of community health centers, for example, federally qualified health centers, are actually in the business of incentive compensation. And I can also tell you that outside of a few organizations, incentive compensation is a very, very small part of provider pay. In the health center world at large, it's less than 3% of total pay. So there may be programs out there, but one of the things we can tell you about them is that they're not generating a lot of money. So if the sales pitch we're getting for an incentive program is because it's essential, because everybody needs it, that's just not true. What's another reason? To further reward good performance. Well, that's a great reason for an incentive plan. I'm a champion of that. I would rather you did it in base pay, but if you have somebody who has good performance and it's above expectations, there's no reason why you wouldn't. That's probably the best, and frankly, I will argue it might be the only good reason for an incentive plan for your providers. To motivate poor performance. That's probably the reason that I'm given the most. We have providers who are not reaching their productivity expectations, so we need to lower their base pay and give them an incentive. Incentive plans don't work to motivate performance. They will in some situations, so I shouldn't make that blanket statement. They will work with some people and they will work in some roles. But what I would suggest you do before you even contemplate the idea of motivating performance through incentives is to do a lot of reading on motivational theory. And I've got a book for you to read, Daniel Pink's Drive. I don't know Daniel. I don't get a penny for suggesting that you read his book, and I think you can get it for less than $10 on Amazon Kindle edition right now. I've probably read this book 20 times, and I still pick up something new every time. The importance of motivational theory is understanding when people change their behavior and why they change their behavior, and how rarely money is an impetus for changing their behavior. Poor performers do not improve their performance with incentive plans. Good performers often do because they say, why not? Let's make some more money. But poor performers don't. And putting a lot of effort into fixing performance for people with a system that usually won't work to do that isn't a good idea. So read up on that. Read this book or any similar book to really get an understanding of what motivates people and why incentives are not always the answer. So if you decide you are going to go through this anyway, I want to talk about what we know about incentives. Balancing multiple and conflicting objectives is very difficult. So when we are developing an incentive compensation plan, it needs to be very simple. Because if we have 3 or 4 different objectives, hey, we're all people. We're going to pick working on the ones that we like. We're going to pick working on the ones that are easiest for us because that's just what people do. Providers, at least in our research and the research of a number of other organizations that we've mentioned in prior programs, value stability and predictability over the amount. It's better to know what you're going to get than just know that you might get more if some things that are not under your control happen. We do know that higher productivity is correlated with higher compensation from our research. And we also know that higher productivity is correlated with participation in incentive plans. So doesn't that mean that incentive plans are good for productivity? Well, no, because one of the things we know is that the incentive plans aren't paying very much, and health centers with incentive plans typically pay higher base salaries. So if somebody tells you X is correlated with Y, make sure that there's causation there as well, because in our research, the incidence of incentive plans doesn't seem to be the trigger for higher performance. It's got a lot to do with other things. In incentive environments, what we know from our research is that the middle 50% of performers basically perform about the same way, whether it's an incentive environment or not. Higher performers do perform at a higher level in an incentive environment, but lower performers actually perform at a lower level in an incentive environment. And it's actually quite fascinating for those of us who like to look at numbers like that to see that it appears, and again, correlation is not always causation, it appears that that incentive environment actually results in lower levels of performance from those who are already lower performers. So what we have to recognize is that from a motivational perspective, there are things that we can or can't do, or things that we can or cannot accomplish. We also recognize that there's really no real evidence on objectives other than productivity that we've got to work with. So we don't know what the incentives are going to do for us, for example, for improving quality or improving participation in other activities. So if we are going to design an incentive, what do we have to think through? Well, we have to think, again, very slowly and very deliberately. Number one, what are the objectives? What is it that we are trying to achieve? Can our objectives be met in any other way? So is there a way to change the performance of, change the job duties of other people in order to increase our no-show rate, for example? We need to ask the question, can the plan that we've designed actually achieve the objectives that we have put in place? That is, will we be able to design something that will effectively result in the results we want? We have to ask the question, what are we willing to pay to get the results? Clearly an extremely important question, because we have to find out what is the trigger, and will that trigger be enough to change behavior? My argument is going to be it probably won't, but in any event, we need to know what that amount is. We need to look at it and say, okay, is a quarterly payment of $100 going to get our providers to see 3 more patients a day? That's a rather absurd example, which was designed to be a rather absurd example. The idea being that we have to know what these numbers are going to be if we are going to be able to have any success at all in developing a incentive compensation program. So what are the things that we have to be concerned with? Well, I'm going to give you 10 of them. And there's more than 10, but I'm going to give you the 10 that are the most obvious and the most problematic. And they're illustrated as a little circle here to show you how they all impact each other. And I realize these are very small, but if you have a copy of the slides, you can kind of look at them more closely. So what are some things that we have to be concerned with? Number one, and probably most importantly, for any incentive plan anywhere, the objectives have got to be fully under the control of the individual who you are trying to motivate. They literally can have no excuses for why their performance and their performance alone impacts the results, which leads to our second question. There's no easy excuses. So if we talk to people in incentive environments, as we have done for years, talking to providers, for example, one of the first things that comes up are what I would call the easy excuses. Well, sometimes there are front desk people that like one provider over another and give them all of the easy appointments, and somebody else gets stuck with all the hard ones. Or perhaps I'm in an incentive plan, I'm an internist, and there are pediatricians in the plan, and we know that pediatricians can see more patients than the internal medicine folks. There are always going to be easy excuses as to why we can't perform at a certain level until we have removed all the easy excuses, which goes back to the points from earlier in this session and the last 3 webinars, the idea that you need to have all of the other things taken care of. That is, everything has got to be at the point where it is now fully under the control of the individual you want to motivate. It won't negatively impact others. When we do have these sort of situations where things are under control, we don't want people fighting. We don't want our providers fighting for patients and fighting each other. We don't want one person's excellent performance in an incentive plan to take away from somebody else's ability to generate results for themselves. So we have to cross-reference, how is this going to impact anybody else? We have to recognize that our objectives have to change. An incentive plan that has the same objectives year after year is going to be unsuccessful, in part because it becomes sort of an expectation that if people perform at a certain level, they're going to hit this amount of incentive. And if they're going to do it that way, you might as well just put it in their base pay. So objectives have to change, and they have to change based on the needs. There can be no unanticipated results. And this is a real big concern. And frankly, it may be a concern even more with attempted group incentives or company-wide incentives as opposed to individual incentives, is that if someone does what they're supposed to do, other formulas can't stop them from being paid. So frequently our finance folks will tell us, okay, well, this is great. We can pay this incentive, but only if we hit these other numbers, because that's how we're going to pay for it. Well, if our folks that we're trying to motivate or we're providing an incentive to don't have control over those other numbers, it may very well happen that they will have done everything they were supposed to, but they still won't get their incentive. So that certainly worked from a risk management perspective from our finance people, but it's a slap in the face at the people who we were trying to motivate. So everything needs to be under the control of these individuals or it shouldn't work. It needs to be frequent and timely. Annual incentives, when we're measuring things quarterly or monthly or weekly, are too far separated from the behavior that we're trying to motivate. So they have to be paid in a reasonably quick span of time after the performance that we're trying to achieve. And of course, the reward is sufficient, has to be sufficient to achieve change. So a $250 monthly award for a front desk receptionist may be great, but it's probably not going to do anything for our $180,000, $200,000 family physicians. Progress has to be frequently reported. Why is that? Well, it's got to be frequently reported so that we can see how we're doing. If we believe that people are going to be motivated to do things by their own results, they have to see their results. They have to know that what they are doing is leading toward what they're expecting to get. The objectives have to be easily quantifiable. And by easily quantifiable, I mean exactly that. We have to be able to count the number of encounters or measure the quality outcomes or count the number of hours spent doing community service or whatever it happens to be. Those things need to be easily quantifiable, and then there has to be no need for exceptions. And I will tell you that in my experience looking at a lot of incentive plans, this is where they fall completely off the rails. Because we may take a simple measure, and let's just take productivity because it's the most typical one, even though it may not be the best. The moment we set a number in place, we start creating exceptions. So we create an exception for our assistant medical directors to give them another 20 encounters to account for the 2 hours that they have to be in meetings in 1 year. Or we will add 5 or 6 encounter credits for something else that somebody's doing or for how many hours of continuing medical education they have. Sometimes these things get so complex that there is absolutely no relationship whatsoever with performance and the numbers that people have. And at the moment, we're working to try and detangle one of those incentive plans, and it is a nightmare. Every one of those little individual thoughts, every one of those little exceptions that were designed into the plan made sense at the time. But by the time all was said and done, it looks like the United States tax code. And I don't think there are enough volumes to actually describe how some of these incentive programs come in place and how they pretty much lose all of their value. So I've deliberately intended to make this sound impossible, not because I don't think you should do it, but because I think you should understand very carefully how much risk there is and how difficult it is to do it right. This is not something that you do after attending a seminar at a primary care association conference. This is not something that you do after reading an article in a journal. This is something that you think through very carefully, systematically, looking at every possible thing that can go wrong. And that's what people don't do. People tend to look at how wonderful this plan is going to change things, but they don't look at what could go wrong. And the going wrong is the most important part because, as I noted before, you only get one chance to do this. So what are the things that you can do? Things you have to do. In the planning process, even the contemplation of some kind of incentive plan, you have to involve those folks who will be participants. A death knell to an incentive compensation plan is when you have everybody in administration designing a plan and it doesn't include any clinical people. Folks may think they know what they're doing, but they don't. And the participants will resent the fact that they were not included in the design. So make sure you involve those who will be participants. And that doesn't mean the medical director, it means an actual physician or a dentist or a hygienist. Involve those people who will be participants. Involve all of those who will be affected. And finance will be affected. They're the ones who are trying to find the money to pay for all this. Look at all of the different areas of the organization that will be affected by what you're trying to accomplish. If you're trying to accomplish increases in productivity, make sure you see that you can support those increases in productivity, that you have the number of exam rooms, that you have the number of support staff to handle it. Because all the wonderful planning you do, if it actually works, you need to support it. So make sure that you're involving everybody who's going to be affected by the results. Model every possible result, not just the ones you want. One of the big things that people do is look at the rosy possibility. This is what will happen. This is what we're planning on having happen. Look and see all the possibilities of what might not happen or what might happen that you really don't want to imagine. This is why, as I noted earlier, reading a book, attending a seminar, reading an article is not the answer. You need to talk to people who have gone through this. And trust me, don't even just take my word for this. Talk to other people. Some may tell you that everything I've been saying is wrong, and that'd be great. That means they had success. But I will tell you that if you talk to enough people, you will find people who will give you all of the things that have gone wrong that will make sure that you don't make the same mistake. When you're executing it, it's extremely important to test and test and test again. Don't design a plan in late November and impose it on the entire organization on January 1st. That's almost a guarantee of failure. When we're testing, we need to, as I noted earlier, model to see how it would work in a number of different situations, and then pick a location as a test. Pick one of your clinics, not all of them. Pick one of your departments, not all of them. Give yourself enough time to find out if it's going to work. I personally would suggest a minimum of a year of testing of a plan before you implement it across your entire organization, because you have to know what may or may not happen, and you have to know that if something bad happens, you've limited the damage. So test and test and test again. Use a trial for at least a year and communicate constantly. Even when you think you've communicated too much, accept the fact that when you communicate a plan, no matter how brilliant your materials are and how wonderful your PowerPoint was, there's a high likelihood that some of it will not be understood. So communicate again and again, and remember that you have one chance to get it right. So with respect to group incentive plans, and I recently did a program for a primary care association on this, they said, well, what can you say about group incentive plans? Incentive plans are a pain, as I've tried to make clear throughout this. Group incentive plans make regular incentive plans look easy, and that's a quote from me. I strongly discourage anything in a group incentive environment as long as those conditions that we have discussed earlier still exist. If our base pay program isn't straight, if we have too much turnover, if we have issues, whatever it is, if programs are a pain, like I said, if our single programs are a pain, realize just what's going to happen when we put that in a group. So if I am going to ask you the question, what should you do before incentives? Change your organization design. Make sure that there are enough people in the roles that will provide you with the results that you want. Change job content responsibilities. Sometimes that's what it takes to get work done. An example of this would be if you are trying to improve some of your measures related to things like no-shows or follow-up calls. Before you jump into the idea of let's have an incentive plan to do this, change the job responsibilities. Give your front desk folks the requirement to call patients for the next day, or look at your reminder calls for future appointments and things like that. Make those part of job duties. You don't have to go to the incentive route where it presumes that it's okay if you don't do it. Make it part of the job responsibility so that there is no issue. So change your job content and responsibilities. Implement a competitive and fair base pay plan, which is great, and then provide training to make sure that everyone is actually doing the work that, or is able to do the work that you have for them. Make sure your employees are capable. If you have a group incentive environment and you have 2 or 3 people that are not able to pull their weight, the plan is going to fail and folks will resent them. Does everyone in this plan have the skills? Are they engaged? Are they actually there and working for you on a day-to-day basis? Are any of them holding you back? It's unfair to have somebody in a group incentive plan that is pretty much guaranteeing from the beginning that the plan will not succeed because they will not pull their weight. This is not going to help anything. If you're really going down that road, it really would be better to replace some of those folks who are going to be causing you more problems than they're doing you good. So let's look at some key takeaways. I covered a lot of ground here with the desire basically to make some points for you to think about rather than to give you answers to what you should have and how you should do it. My key takeaways for you are most barriers to improvement are structural. We've talked about that throughout our webinar series. Organization structure and job design, processes that don't support our initiatives, having the wrong people in the job, and very importantly, having a base pay program that doesn't support recruiting and retention of the right people. Those are structural. Those are not things that are going to be improved through performance management or through, changing the way you're delivering pay or through incentive plans. Those are the kinds of things where you can improve the performance of the organization by redesign before we get to individual things. We've spent a lot of time, and the whole purpose of this webinar series was to talk about how base pay is so key in everything that we are trying to accomplish. So when we talk about incentives overlaying that, don't even contemplate them until you know exactly what you want to accomplish. I talked about some of the things that are reasons for people to have incentive plans. If you're designing one and you have a group involved in this, make sure that you know exactly what it is that you're trying to accomplish. If you're trying to change behaviors, look at exactly what behaviors need to be changed and really look honestly at your plan design and say, is it possible to change those behaviors through the plan? Is it possible to change those behaviors with the people you have? Don't do it until you've addressed those structural issues, till jobs and processes have been modified to take care of all those things you're trying to accomplish. Don't do it until you have the right people in place, that they've been properly trained, and your pay system is at a level that minimizes turnover. All of your provider incentive compensation programs will fail if the support staff is not in place to make sure that providers are able to see the number of patients that they need to see in order to get their rewards. Finally, see what you can accomplish without incentives. Try to do things in a more structured way that doesn't rely on individual people performing at a particular level based on how they feel that particular day. Try to build things into the way that you do things rather than leaving them up to people's desire to make more money as a result. Incentives may be able to help after all of that is left over. And that's why I do suggest to you that you take care of everything else first. Once you've done that, once you get to the point where there are no more excuses for poor performance, or there are no more excuses for improving performance to what the organization thinks it should be, then you get to the opportunity where you can look at whether the failed performance is a result, or whether the failed results are a fault of performance or the fault of structural issues. At that point, you're in a situation where you can now look at the idea of incentives and how they can work. So as I noted, we've covered a lot of ground here. Hopefully you will have the slides to look at, and certainly if you have any other questions on this topic, please do not hesitate to contact us. I'll be happy to give you whatever answers I can. There are some resources that we have available at our website. Also, the 2 blogs that we have, one that is devoted particularly to health center related topics. You will see a lot of conversation and data and the like on pay, on provider pay, on incentive pay, and many of the other issues that I've talked about. I want to thank you for participating in as many of these seminars as webinars that you had, as you have, and I hope I've been able to provide you with some insights. Thank you again, and we hope to be talking to you soon.